So I'm going to talk about the forever changing roadmap for type 2 diabetes today. As an introduction, as you know, obesity is an emerging epidemic increasing among especially young people. Type 2 diabetes is also increasing among young people, and therefore we have a potential for a worldwide public health crisis. This is all because of the eating out, of course, as you know. And it's not only a local epidemic, it's also global. The World Health Organization estimates that more than 180 million people worldwide have diabetes, and this number is likely to be more than doubled by 2030. Over 20 million Americans suffer from diabetes, and an additional 41 million have pre-diabetes. That's a huge burden for the medical profession, as well as financial burden. Approximately 1/3 of those individuals with diabetes are undiagnosed, and this is where we come in and try to identify them and help this huge group of people. It is from hospital statistics, we know that diabetes is the fourth most common comorbid condition for patients admitted to the hospital. In 1997, diabetes was present in almost 10% of all hospital discharges, as well as 29% of patients undergoing cardiac surgery. These are kind of epidemiological studies or retrospective evaluations for patients who are in hospitals. And diabetes causes a twofold to fourfold increase in the rate of hospitalizations. It increases also the length of stay by 1 to 2 days, as well as recent studies has showed that the hyperglycemia in hospitalized patients complicate numerous illnesses and is an independent risk factor for adverse outcome in hospitals. In the US, affects more than 17 million people and increases the risk of heart attacks and strokes by more than threefolds. It's a leading cause of blindness, new blindness, and end-stage renal disease and amputations. 17% of all deaths after age 25 is related to diabetes, and it costs more than 100 billion per year, and almost 15% of all hospital admissions. Of course, it's all related to the problems in the society, all from eating out. So increases eating out, eating high carb, high fat diets, increases obesity. Also, our society is an aging society with increasing age, and the growth of ethnic population with high prevalence of obesity and decreased physical activity all leads to diabetes. So the prevalence of glycemic abnormalities in the United States, that does just not say diabetes, even a glucose intolerance or being fasting versus post-meal abnormalities. We have the U.S. population was estimated to be 275 million in 2000. We have diagnosed type 2 diabetes 10 millions, and as you can see, 10 millions is type 2 diabetics. 1 million type 1 diabetics. There is almost 50, like half of the diagnosed diabetics are also undiagnosed, and the rest with glucose intolerance. See this big part of the pie? These are all undiagnosed and or pre-diabetics. They will be diabetics over the years. And also treatment for strategies are, this is also some studies were done to see all these diabetics, if they have what we achieved if we adopted treating strategies, just diabetes, hypertension, and cholesterol. And as you see, this is what we found out, that we found out around 59% are uncontrolled, and we are only controlling 41, as well as for the hypercholesteremia, we're only controlling 41, and the same for diabetics. We have only 42% of our diabetics achieving a hemoglobin A1C of 7. So we're really not doing a good job, in spite of trying our best. So we, as a scientific society, we decided, all of us for decades now, trying to find new options for diabetics, type 1 or type 2s. Today I'm going to concentrate on the type 2. So the need for new option has risen, and despite the advance in options for treatment of diabetes, optimal glycemic control is often not achieved. Hypoglycemia and weight, when you treat diabetes, the pitfall is that weight is going to increase, and therefore, and hypoglycemia, this is the price we pay for tight control of diabetes, and therefore the weight and hypoglycemia both interfere with the implementation and long-term application of intensive therapies. Treatment has also centers on insulin, either through direct insulin administration or through oral agents that promote insulin secretion or sensitization. And this has been our outline of our strategies for managing type 2 diabetes for a long period of time. So until 1995, we have only sulfonylureas, and for the patients in the audience, as you know, like glipizide, glimepiride, which are the glucotrol, the regular release, extended release, all of you know metformin, glucophage, and Amryl, all of these medications, until like 1995, the only sulfonylurea and insulin were available to treat diabetics. Currently, there are 5 classes of oral agents are available. The alpha-glucosidase inhibitors, which work on the disaccharides in the stomach and causes a breakdown of glucose in the intestinal lining, as well as the miglitinides, if you have heard of, like Prandin, and thioglitazones like rosiglitazone, which is Actos and Avandia. Big one-ides are the metformin, glucophage, and the sulfonylureas. We have first generation, second generation, and third. Between the and the most commonly used is the Amryl, the glimepiride, as well as glucotrol XL and the glyburide. So we use a stepwise management in the treatment of type 2 diabetes. The number one is the lifestyle modification, which most importantly is change in diet, and lower carb diet, low glycemic load, low glycemic index diet, as well as exercise strategies and of course physical activity. This is the goal. This is always, as you see, it goes all along all the stages. This has to be present along all the stages. If you take medications without trying to increase physical activity and or change in diet, those medications really don't work. And I tell always my patient, we can eat through everything. So if we use all these medications and we do not change our diet or physical activity, those medications will finally fail. And of course we can use monotherapy, which means one agent at the beginning, and then of course if one agent doesn't work, we don't stop it and start, we add. The whole idea is to try to control diabetes from different aspects. Type 2 diabetics usually are known to be insulin resistant, as well as there's some insulin secretion issues, and therefore we use a combination therapy by which we target the insulin resistant using the sensitizers, and that includes the glucophage, metformin, the big one-ides, as well as the thioglitazones like Actos and Avandia. And we will talk about Avandia and all. I'm sure you heard about it in the news. So these are the sensitizers. These medications sensitize your tissue to your own insulin, and therefore decrease the burden on the pancreas in the presence of high glucose. Then the additional one would be to add something to help the pancreas to secrete more insulin, and these are called secretagogues. And this is, we move on, we add to it, and we add to it the combination therapy. If that fails after we adding the secretagogue and the sensitizer in combination, we keep it and we add insulin. And sometimes we add insulin only for like a basal therapy, like long-acting insulin, like Lantus and Levemir, which is a glargine, and the Levemir. And also sometimes we, in addition to using sensitizer, we use meal bolus insulin. That is the final stage. And during all these stages, we always use lifestyle modification, including physical activity and diet. So the oral hypoglycemic that is available, as I mentioned some of them, the secretagogue are the sulfonylureas, the ropiglenide and the natiglenide, which is the available in the market currently. The big one, we have only the metformin or the glucophage, as we all know, and also the alpha-glucosidase inhibitors, the ascarbose and miglitol, and these are have some side effects. It is used but not commonly used currently, and the glitazones, the pioglitazone and the rosiglitazone, which is the Actos and the Avandia. Mechanism of action, the ones that cause secretion of insulin, it works on the pancreatic beta cells, stimulate more insulin secretion, and increase the basal and or postprandial insulin secretion. This is their mechanism of action. It is works on a functioning beta cell. We need functioning beta cell. You can't use it in type 1 diabetics. They are the sulfonylureas and the ropiglenide. They decrease hemoglobin A1C by 1 to 2%. So they're all modest, really, but in combination may help us. And with the diet is the major powerful addition to all of this. Then in combo, they will work to achieve the very strict criteria for hemoglobin A1C in type 2 diabetics. The American Diabetes Association recommend below 7. The ACE, the American College of Endocrinologists, recommend 6.5, below 6.5. So it is hard, and therefore the effect of these medications is really modest, 1 to 2%. Sulfonylureas 1 or 2 times daily. We use them in divided doses. And the secretagogues like Prandin, we use it pre-meal, so it's 3 to 4 times daily. And the most important side effect is weight gain and allergies, of course, like any other medication. Of course, the main risk is hypoglycemia as they induce insulin secretion. Anything with insulin, the main risk is hypoglycemia. The metformin is also a very famous orphan drug for the biguanides, decreases hepatic glucose production, and this is the area where people wake up with a high glucose in the morning and they wonder why, and all day long they run well. You will hear this from type 2 diabetics. I do very well during the day, but I always wake up with high sugar. This is because there's a tremendous amount of glucose production from the liver at night, and therefore diabetics wake up with high sugar in the morning, and this medication decreases this activity or glucose production. And also it has to work in the presence of insulin. Therefore it is really limited to type 2 diabetics and has a side effect of increased lactic acid in the blood, and therefore in insulin deficiency, and therefore or in renal abnormalities, and we use it only in patients with type 2s. Decreased hemoglobin A1C, as you see, is very modest, 1 to 2%, and we use it 2 to 3 times daily, cause diarrhea and nausea, and the major problem is lactic acidosis, as I mentioned. These are all old medication. I'm going to try to go over very quick, and then we'll talk about the very new ones. The glucosidase inhibitors delay carbohydrate absorption. It used postprandial it's very good for postprandial hyperglycemia, not the morning glucose issues. It decreases even less, 0.5 to 1%, used 3 times a day before meals. A main problem is gas, really, and sometimes it causes liver enzyme abnormality. The glutazones, we all heard lately about the glutazones, especially the Avandia, which caused, now it's black box by the FDA in regard to increase myocardial infarction and heart failure. It enhances tissue response to insulin. It's a sensitizer like the biguanide, metformin, glucophage. It works in the presence also of insulin and insulin resistance. So it increased the sensitivity to insulin. Again, it's modest, between almost 1 to 1.5%. It's a once daily dose. The most problem is weight gain, anemia, edema, but really, and the congestive heart failure. And there are accumulating evidence of increased risk of coronary artery disease. So the monotherapy maximum therapeutic action, this is just to show you that really none of them reaches more than 2%. And what do we do about somebody who has hemoglobin A1C of 10 and 11? Without diet and lifestyle modification, none of these, this is monotherapy. Additional, they're not synergistic, sometimes just additives and sometimes not. So basically, all of these medications, they have modest effect on glycemic control, and therefore additional medication is needed or multiple therapy is needed. So these are medical benefits we all know about, and the site of action, this is just schematic representation for exactly what I talked about. It's in the pancreas, there's impaired insulin secretion, and therefore all these secretagogues increase the insulin secretion, like the sulfonylurea and the meglitide. And the metformin works on the liver, decreases the glucose production in the morning. And on the muscle, the ROSI and PO work, and actually thought also metformin works to decrease the insulin resistant, and of course in the carbohydrate metabolism work, acarbose and miglitol. There is a difference between the response of a healthy subject and a diabetic patient to a carbohydrate meal. As you see, insulin in a normal subject, this is the blue mark, in response to a carb meal, to a high carb meal, normal subject produces a surge of